No, no, no.
And do you want me to put it on full screen?
No, not yet.
Not yet. Okay.
So, okay. I think that let's wait just 1 minute to see if more people is online.
Bianca, can you see people?
Yes, I'm
okay,
seeing that
wonderful.
people is joining.
Okay.
So, good afternoon and welcome to the second online training session organized this year by Active Citizenship Network, the European branch of the Italian NGO Cittadinanza Attiva. It is part of the 2023 edition of the European project VaccinAction, protecting the value of vaccination during and after the COVID-19 pandemic across Europe, impact, experiences, and perspectives from citizens and patient advocacy groups and relevant stakeholders. Probably among those who are connected today, there are some participants who may not have had the opportunity to participate in our previous initiatives on these topics. And therefore, I would like to recall our commitment on vaccination policies. Without making a long and pointless list of activities carried out over the years at the national and European level by the association I work for, it is good to recall that we work to increase the number of civil society actors involved in vaccination policies, support the life course immunization approach for all vaccine preventable diseases towards both political stakeholders and the general public, and also provide decision makers and stakeholders involved in the definition and implementation of vaccination policies with a civic perspective that complements the perspective of other qualified actors involved in the issue. Building alliances and dialogue with institutions in a multi-stakeholder perspective are long-standing characteristics of our approach. And today, we continue our efforts to strengthen adult vaccination in Europe and to mobilize stakeholders. In particular, today, we focus on the crucial role of vaccines in the fight against AMR, exploring why next-generation antibiotics alone cannot effectively address the AMR crisis. And we will delve into the cause-effect relationship in AMR mitigation. Antimicrobial resistance is one of the top 10 threats to global health and often underestimated. It surpasses car accidents and cancer in dangerousness, but apparently it is not a priority in Europe and the member states' public health policies. Fighting antimicrobial resistance requires preventive policies and expansion of vaccination programs. And public awareness and involvement efforts are crucial. As always, in order to be better informed on the topic, we invited an independent expert, and today we have the honor of having Professor Adam Cunningham, who is Professor of Functional Immunity at the Institute of Immunology and Immunotherapy at the University of Birmingham, and co-director of BactiVac, which is the Bacterial Vaccines Network, as our lecturer. Before giving him the floor, I would like to hand over to Mariano Lotta, who is the director of Active Citizenship Network, for a quick opening remark. Thank you.
Thank you, Bianca. Welcome and good afternoon from me as well. A few days ago, on December the 5th, the European Commission adopted the European For Health 2024 work programme to implement the main priorities of the European health policy within the framework of the European Health Union. As Stella Kyriakides, the European Commissioner for Health and Food Safety, said, civil society has a crucial role to play in reaching out to our citizens. This declaration is a great achievement to be proud of, because the active role of patient advocacy group of citizens organization in supporting public policies that have the interest, the needs, the expectation of the European citizens at their core, and that have health as the main common good to be safeguarded, is not recognized in all sectors and by all the stakeholders. On the negative side, however, it must also be said that in the mentioned European for Health 2024 work program, vaccination policies are the great absent. And this also clashes with the Council conclusion of only 1 year ago. In fact, on 9 of December 2022, the European health ministries defining vaccination as one of the most effective tools for preventing disease and improving public health as one of the key priorities of the Czech presidency. On that occasion, my organization, together with many others, welcomed this important initiative, which highlighted the urgent need to fight vaccination hesitancy and to strengthen European cooperation in the field of vaccination for the future. In particular, the conclusion emphasized that even vaccination policy is in the responsibility of the member states. A more coordinated European approach would be helpful in preventing and limiting the spread of vaccine-preventable epidemics and diseases. In light of this, and taking into account the 2024 scenario, I believe it is necessary to emphasize the key role of vaccination policy in all the areas that will be particularly addressed by the 2024 work program, including the European Beating Cancer Plan, the cross-border health treats, health promotion and disease prevention, global health. Today, we will try to answer the following question. What role do vaccination policy play in addressing, as already Bianca mentioned, one of the most urgent threats to global health, but totally underestimated by the public, represented by antimicrobial resistance? Antimicrobial resistance is an issue we have been working on for years, both at the national level here in Italy, where my organization, Cittadinanza Attiva, is the only civic organization officially mentioned in the national plan for the fight against antimicrobial resistance, but also we are committed on it at the international level, where, for instance, we are officially accredited in the newborn AMR multi-stakeholder partnership platform, recently established by the 4 intergovernmental organizations: the Food and Agriculture Organization of the United Nations, United Nations Environmental Programme, the World Organization for Animal Health, and of course, the World Health Organization, which organized its first meeting of this new platform here in Italy in November in Rome. I am sure that a better understanding of the role of vaccination policy will be of great benefit to us as we continue our effort both on the adult vaccination front and in our effort to counteract antimicrobial resistance. We look forward to learning more about the role of vaccination policy in helping to fight AMR, because as always, being well-informed and up-to-date is often the best precondition for promoting greater activism. So we kindly ask all of you connected today to make the most of this opportunity by interacting with our distinguished expert, whom I thank in advance, and not hesitating to ask him questions. I thank you for your attention, and of course, I wish you a fruitful webinar. Bianca, the floor is yours again.
Thank you, Mariano. So I remind everyone that if you want to ask the professor questions, you can do so at any time using the chat box. And so please, Professor Cunningham, the floor is yours.
Thank you very much. I'll just turn this into presentation mode before and hopefully you will have a clear screen. Is that correct? Can we just make sure, and then I'll just put that onto laser pointer so everyone's clear. Is that you're just looking at the slides? Yeah. Fantastic.
Yes.
So thank you very much for inviting me along to talk today about AMR and vaccination. And hopefully some of the principles I raise and some of the discussion points will be useful and emphasize the role vaccination will play. And so my aim in the next 30 or 40 minutes or so is really just to give an overview of some aspects of this as to allow us to have an open and frank discussion about what we know and the clear advantages of vaccination in dealing with the infections and where areas need to greater understanding. And so because of my role in back-to-back, I'm going to give a very, very quick introduction to back-to-back. Then I will go on and discuss about the risk of infection in the context of age and immune function and status. I'll give you an overview of what interventions we've got to control infection, the differences between antimicrobial and vaccine use and the concept of resistance, what that means in these contexts. And then the evidence that vaccines reduce antimicrobial use in children and adults, gaps and needs, and then of course open for discussion. So the evidence base for this is global. I've tried to keep a very strong emphasis across the EU and because of the nature of this discussion, but it involves data from other high-income countries as well as other global sources. And actually what as was mentioned in the introductions is one of the key things about this is that this isn't the AMR isn't a local issue. This is a global issue. It's one flight away from affecting us all. Okay. So introduction to back-to-vac, and our mission is to accelerate the development of vaccines against bacterial infections, particularly those that are relevant to low middle income countries. And the reason we formed is because there are over 8 million deaths yearly from bacterial infections, but there was no network to channel interest and bring together the various stakeholders here so that we can try and accelerate the production. For anybody who's a specialist in this, then we provide funding to support the community, but probably more relevant for today is the fact that we provide a degree of advocacy for the development of bacterial vaccines. And this is through partnership, collaboration, and engagement with industry. So, and these are our contact details, but if you just Google back-to-vac, it'll come up. So I'm going to start with a slide from the pre-antibiotic era, or data is from the pre-antibiotic era, and because this really shows what we face. So this is a slide taken from a US collection, which essentially looks at the wars in from the middle of the 19th century to the middle of the 20th century, up to the Second World War. And then it compares and contrasts the proportion of people, the number of people who died from taking part in warfare, and those who died from disease associated with being at war and with travel. And what's quite striking is that wherever you look around the globe, so for instance here, this is the Crimean War in the mid-1850s, is that you can see disease plays a major role. So here the ratio is roughly 9 or 10 to 1 of those who died from disease compared to fighting. If you look at the American Civil War, it's greater than 1 to 1. And we can go through all this. This is Franco-Prussian War, 1 to 1. The Sino-Japanese War, 16 to 1. It's only really at the 20th, by the 20th century, is that with when we incorporate scale into this, is that we can see that we can start to control the disease. This is after the establishment of the germ theory of disease. We able to start to this, and by the Second World War, we've actually become much better at killing each other through warfare than killing our soldiers through disease. And so in some ways you can measure progress that way in an ironic way. So really the other take-home point I really want you to remember here is that, of course, soldiers at war are typically in their healthiest years of life, in usually late teens to 30s or so. And this puts them in the nadir of risk of infectious disease here. And so it's very well established that the risk of infectious disease has a first peak in the first months or years of life, certainly up to about 2, 3, 5 maybe. But then after we got a relative sparing until we get approximately over 65, and then you start to see this big increase in here. Now, immunologically, and it is our immune systems which overwhelmingly save us from the consequences of infection, is that we can think about this as a newborn infant or a very young individual as being a relatively blank canvas immunologically. And then we can think of somebody who's much older as actually having a lifetime's worth of immunological experience, but actually they still become susceptible to a range of infections. So we want to try and understand how and why this is, but also I would also like to point out is that in the main, vaccines work in both these extreme age groups, and I'll come on to discuss that in a bit later on. This is important because what we really want to be able to understand is how to prevent disease. And so if we just look at bacteria now, this is bacterial infections, and the vast majority of these there are no vaccines against, is that we have in 2019, it was estimated that just to 33 bacterial pathogens, there were nearly 8 million deaths. So if we look at this in the global scale of things, this is 1 in 7 of all deaths globally. And in that year, it was after cardiovascular disease, it was the second leading cause of death. So now if we look at this in the context of antimicrobial resistance, which I'll refer to continuously here as AMR, is that 5 million deaths near enough were associated with AMR. And then 1.27 million deaths were directly attributable to antimicrobial resistance. And this number is going to grow. So as I mentioned, these figures coincide with the risk of death and risk of infection at the ends of life, at the extremes. And so if we look at the distribution, and this is the incidence of bloodstream infections from an organism called Escherichia coli, E. coli, it's nearly always referred to, by age, you can see that in the very young is that there's a peak, relative sparing, and exactly as I showed in that representative cartoon graph before, as you get older, the risk gets far, far greater. We can see that this happens for most infection. Another one which is really, really important here is strep A infections, and you see a early and a very late peak. But it's not every infection, and this data is from the USA, but it's pretty much identical to what we see in Europe. It is that for COVID, there was a relative sparing of the very young, which we were really grateful for as a society. And most of the deaths were in the elderly. If we now look at what does being older mean, it means is that you have an aging immune system, but also you are likely to pick up many other secondary diseases, non-communicable diseases, for instance. And I've just taken a couple of examples here. Diabetes, which can be split in simple terms, can be split into type 1 diabetes and then type 2 diabetes. And type 2 diabetes is most associated, of course, with obesity and lifestyle factors. And then if we look at these types of infections, either bone infections or heart infections, meningitis, pneumonia, or sepsis, or even if we just pool them as death from infections, we can see is that having type 1 diabetes leaves you wide open to having all of these and to greater risk of these and poor outcome, as does type 2 diabetes, but not to the same degree. And then we can, as we get older, we have many other comorbidities and chronic kidney disease, for instance, and patients undergoing dialysis. So chronic kidney disease is if a patient is on hemodialysis, that patient has a 1 in 5 chance of dying from an infection every single year. Cancer predisposes you both, and then the treatment for cancer can often predispose you because it wipes out your cells, your immune cells, as can some autoimmune diseases and the treatment for those. So we can see how you can have a relative healthy immune system. You can still maintain it when you're older, but that your other factors can influence your risk. And another factor I'd just like to introduce here is what vaccines can do. So if we go back to COVID, is that you had one pathogen with a range of different outcomes across the life course, independent of your age up to a point. But that if we vaccinated, then these risks were diminished in all age groups. And I'd just like to emphasize is that the reason that we have now a reproducible mingling across in the last 2 years after the pandemic has been the introduction of the COVID vaccine. It de-risks exposure to COVID. So that gives us a great opportunity to understand and appreciate the benefit of vaccination. A simple headline figure when we're thinking about infection is death. It's very usually relatively simpler to collect data on and so on. And if we go back to the Middle Ages, and then when the first outbreak of the Black Plague occurred in Europe, estimates were that between 50% to 2/3 of the population of Europe were killed by this pathogen. But also infections affect other diseases, so-called non-communicable diseases. So, for instance, infection can trigger cardiovascular complications. We can look at the infective endocarditis, for instance, as being a huge burden, particularly in places like sub-Saharan Africa. But it's also a big burden in developed countries in Europe. But also infections can cause cancers. If you get an injury or a burn, then the complication is often because it allows an infection to establish on you, become established on your body. Asthma triggered, often exacerbations are triggered by infection. Autoimmunity is often a consequence of infection and so on. And so when we think about this, a little bit deeper, we can then split this a bit further. I've mentioned COVID, which is obviously an epidemic infection. And these tend to grab the headlines. But actually, in terms of absolute burdens, it's probably these endemic infections which really contribute most to the overall disease burden. And it's these that we have problems being able to control. And so we can, going back to COVID again, shows what happens if we think back to early 2020, what happens in the absence of effective interventions. And that's both a treatment to deal with an infection and also a vaccine to prevent it. And we know that prevention is better than cure. So we got 3 major ways that we control infection. The first are through public health measures, clean water and so on. And these have been fantastically effective at reducing particularly gut-borne infections. We then, our medical interventions really come down to one of two ways: antibiotics to treat the infection and vaccines to prevent the infection. And if we look, then we've got relatively few antiviral treatments. And so this has meant that overall, there's been more interest in developing vaccines. So in terms of licensure, there are at least 15 viral diseases where there's a licensed vaccine. Whereas we have relied really heavily, particularly in the second part of the 20th century onwards, is on antibiotics. We have relied on them so much is that there's been a relative avoidance. There are other factors that contribute to this, but there's been a relative avoidance in developing vaccines against bacterial infections. And so many fewer bacterial diseases have vaccines against them. Complicating this further is that often we don't know whether we're infected with a virus or with a bacteria. And one of the reasons for this is because we have relatively limited diagnostics that can provide insights in real time to determine the pathogen, the nature of the pathogen. And this is important because actually antibiotics will not work against viral infections. So when we're using these in a viral infection, we're actually compounding the problem of AMR and not providing a solution to it. And so in the context of these three pillars, what we're trying to do really is to reduce disease burden. And AMR, as important as it is critical because it impairs our ability to control disease. And so it should always be remembered in this context. So I like to say that vaccines democratize opportunity because they work pretty much equally across the life course in most people. Certainly, the outcomes from having a vaccine in terms of the benefit are much more equal at different times of your life than potentially the consequence of the infection. And so, moreover, there are really quite limited options to treat the active infections, which I've discussed, particularly for viral infections. And this graph helps us to contextualize this, I think. So on this axis, is it just a rough guideline for the numbers of bacterial numbers during an infection. So at the earliest stage, when you encounter the pathogen first down here, you're obviously going to have the fewest number of bacteria. Then if they multiply and increase in numbers and you get sick, then they'll reach a peak. If you're lucky and everything goes well, then your immune system will kick in and they'll eventually control the infection. So where do we, if we now superimpose our interventions on this, where do they hit? So the first one is that antibiotics mainly are used here. So when you're sick, when you've got the highest number of bacteria inside your system in whatever form that takes, that's when you administer the antibiotic. You go to the GP, your physician or pharmacist when you're sick, you get antibiotics at this stage. You don't actually really know if they are going to work for you personally in that specific case. But it's an easier sell because you take the antibiotic and you get better, but you don't know what the cause is. In contrast, vaccines work here. So you don't know when the vaccines were active because in the main, you don't realize is that it's done its job. So at this point, you've got the fewer or probably even your fewest bacteria. And then so this gives this just in sheer numbers game means that the vaccine will work, is more likely to prevent the infection starting because you've got a much lower number of bacteria here. So it needs to kill fewer bacteria to have an effect than it does any intervention at this point. And we can see this in quite dramatic terms if we look at it at these two extreme examples. So these are obviously two infants, and in the context of today's talk, I'm mainly focusing on adults, but they're inseparable overall. Is that this individual, we have no idea whether the vaccine worked in this person. It might have done, and it might not have done. But the key thing is if this individual who is vaccinated against meningitis encountered the pathogen, then it was likely dealt with. In this instance, this infant, there was no vaccine available against this type of meningitis for this infant. The developed meningitis and antibiotics were obviously administered. So antibiotics probably saved the life of this individual, but obviously there were complications resulting from the disease in this individual. And so we can see here, both of these are representations of success, but the vaccine limits the potential for any sequelae of disease to form. Whereas here, in the success looks differently. It's ultimately, it saves lives. But what we want from this is to be able to go back to a previous life or have the greatest opportunity that we will have during our life course. And that's really important. It also means, as we heard in the early introductions, is that it's easy to overlook what vaccines are doing. That's because you don't know when they've worked for you. We have incidences like COVID, where you have everyone vaccinated in a very short period of time with multiple vaccines in terms of boosts, and those vaccines are working to a highly prevalent pathogen experienced in real time within, probably for many people, within weeks of vaccination. Those opportunities are very, very rare. So we don't really know when it's going to work. So the selling antibiotics is much easier because you feel yourself get better. But antibiotics should be used sparingly. And AMR truly is a game changer in terms of how we will be able to deal with our day-to-day running of normal society. And it will change the landscape of medicine. It will change the landscape of our day-to-day lives, because what it will mean is that in the absence of vaccination, is that we have very little options, very few options of what we can do if we encounter a pathogen. So it introduces the randomness of outcome from an infection. And that's not something we're used to in the modern world. So by 2020, 2050, sorry, it's estimated that 10 million deaths will be attributable to AMR. The cost of this economically is enormous. And the distribution is obviously going to be felt in most keenly in Asia and Africa, but no site will be, no region will be left out of this. And as I mentioned earlier, is the way that AMR develops means is that the risk to the local populations are only a flight away. What do we know? We know that antimicrobial resistance develops really rapidly once an antibiotic is introduced. In the laboratory, you can see this within 24, 48 hours of if you put what's called selective pressure on the organism. So it develops very quickly. We're still continuing to use antibiotics and not really reducing usage in any meaningful way as of yet. And this is despite some good efforts now being employed in both high income and low income countries, but it's not sufficient. Additionally, over half of antibiotics are used in veterinary settings, and this includes as growth factors for animals. So the consequences of this aren't just going to be felt when we get sick. The consequences of this are going to be felt in undertaking any routine medicine. So for instance, undertaking a hip replacement will become an extraordinarily risky adventure for the patient, as will colorectal surgery, most definitely. And in the US alone, each year, it's estimated with AMR, the pressures of AMR will increase deaths just from these two operation types to 6,000 a year within a few years. And the problem here is that we rely on antibiotics so much during our day-to-day experiences. and those who are not fortunate enough to have a fully functioning immune system, or for instance, who are asplenic, really rely on these much more, lack of spleen, sorry, are really much more likely to do this. And antimicrobial resistance is already established. And these data are taken from various spots taken around the globe, but actually the equivalent similar data is a similar picture occurs in mainland Europe as well, and in the EU zone, is that and it doesn't actually matter what these pathogens are. The important point is that AMR is already established in many to most of these, and this becomes is likely to grow. And I just want to identify this one organism here. This is an organism called Klebsiella pneumoniae, and we have strains of Klebsiella pneumoniae which are extensively AMR, but this coincides with the development of strains which are called hypervirulent. So you've got strains which have increasing virulence, i.e. you're more likely to become infected if you encounter them, alongside when they're becoming more resistant to antibiotics. This is very concerning. So why is this? Why are antibiotics, where does this problem come from? And it fundamentally comes from selective pressure. Bacteria replicate every between 20 minutes to a day. So they can change their DNA very, very quickly. And so what we find is that as soon as this is a timeline from when an antibiotic was introduced to when the X appears to when resistance was detected. And basically, it doesn't matter about the antibiotic, as the story's the same. As soon as you introduce an antibiotic, the clock is ticking, and very shortly thereafter, you will find resistance against that antibiotic. Against some of these antibiotics, because of the way that they're developed and they were generated, antibiotic AMR exists to that antibiotic before it was used commercially or in as a health tool, and that's because these are not, many of these antibiotics are based on natural compounds. In contrast, if we take a vaccine, and again there are a few down here, is that what's important here is the length of the line, is that for virtually all of these vaccines, there is no meaningful clinical resistance or clinically meaningful resistance. Pneumococcal and pertussis, they're included for slightly different reasons here, but these again are extraordinarily beneficial tools where clinically meaningful resistance in the same way that you see for antibiotics is virtually meaningless, or not a valid comparison. So when you have a vaccine, is that you have long-term benefit. And then what is really interesting here is that the only human pathogen that's been eradicated, smallpox, was this was achieved in large part by the careful administration of vaccination. Vaccines really do work and prevent infectious diseases and the need to use antibiotics. So what does success look like for a bacterial vaccine? So in the main, if you get vaccinated, it'll prevent an infection from establishing. Sometimes an infection will establish, but the vaccine helps that stop from becoming, turning into a clinically meaningful disease. Additionally, vaccines, in even these rarer cases, in the main, reduce the severity of disease if it occurs. And again, going back to what COVID looks like, if COVID, we're very fortunate at the moment, is that the vaccines are holding up against a myriad of different types of strains of COVID, and it's turned a life-threatening disease into one which is largely, not absolutely, but largely restricted to the upper respiratory tract. That's really important, because we wouldn't have had lockdowns, we wouldn't have all the economic and life-threatening troubles we've had from COVID if it was a life-threatening disease in the beginning. This is an incredibly important point. But then the other real way that vaccines work, and we undervalue this completely, is that the benefit they provide persists for many years in the main, and sometimes for lifetime. So, and this is important because when you get vaccinated, you don't know if you're going to encounter the pathogen shortly after vaccination or a long time after, and by that I mean years. The great thing is because the vaccine works with integrating with the immune system, is that this provides long-lasting protection. So estimates suggest that vaccination per year saves up to 10 million lives per year, and that's it across the life spectrum, young and old. And so these figures are from the pre-vaccine era on this column, and then the post-vaccine era here. But what's really most important is this percentage change. Is that overall is that there's been a greater than 90% drop in these infections, and that these are incredibly safe interventions. Is that all vaccine events up to the year 2000 for these are less than 13,500 out of the tens or hundreds of millions of people who've been vaccinated. Incredibly important. So vaccines prevent the reason that the resistance is so limited to vaccination is because if we go back to our graph here, this is when you're infected at this point and you've got a certain bacterial burden, is that when you're vaccinated, this is roughly going to be the highest point in terms of your bacterial burden that you'll reach. The vaccine works quickly, and then the pathogen gets killed off here, so it disappears from the body. And what this means is that bacteria are killed, and so they do not spread, and then you don't have a risk of any evasion or resistance from forming. As I mentioned before, here is when you use your antibiotics. At this time point, you've got lots of bacteria or pathogen present. And one of the reasons is that bacteria multiply is, of course, to encourage transmission. So you're using the antibiotic here, and if there's any resistance here at this time point, is that there's a chance that it can spread, and that's one of the major ways is that antimicrobials act is to or they act here to help cure you, but because it's a numbers game, is that there's a risk of any antibiotic resistant strains will go on be selected for and go on to spread. The other key point is that the vaccines, as I mentioned, provide sustained protection. So this persistence helps prevent resistance from developing. And so this graph puts it in a very simple and probably coarse way, is that antibiotics provide their life-saving benefit, usually for the time that they're being administered. And then they're broken down relatively easily and then excreted. Even the shorter lifespan, even the shorter span acting vaccines, such as these ones, they still do that job for 2 to 5 years. But most vaccines provide that benefit for decades after that final dose. So antibiotics also generally are given because they react with many different types of bacteria. So they don't just affect the target pathogen, they affect those bacteria around it. And that's important because that's another way that resistance develops and spreads. The vaccines are very, very specific. So that's not an issue here. One of the other issues, possibly a negative here, is that they are specific, and that will come on to that in a bit. So we immunologically,
Professor, sorry,
yeah.
We have a question from the audience. So they're asking which factor plays a more significant role in driving antibiotic resistance, the presence of pathogens within individuals or the circulation of pathogens throughout the population? Thanks.
Within or external? So it's a really, really good question. They can't be really separated in that sense. So there's quite a it's quite a complex area, because, as I mentioned, antibiotics are used extensively outside of the human system, such as in veterinary context for animal growth factors. So there's a lot of selection that goes on there. So if we look at some pathogens are human restricted, so those pathogens like the two examples, a key example would be pneumococcus, which is one I mentioned, which is Streptococcus pneumoniae, that colonizes people. So you use antibiotics there, and then develop resistance can develop within that person. Other pathogens cross over the species barrier. A great example would be Salmonella. So Salmonella colonizes other animals, but then because of changes in welfare, depending upon part of the world, animal welfare or public hygiene, is that it can then get into humans and then causes its infection there. And then you give your antibiotics at that time. They're probably not helpful in the main against those types of infections. But then the other thing is that within your body, you've got bacteria which reside in your gut, which are commensal part of your normal flora, and some of those will be antibiotic resistant. And so they have you can get crosstalk between different bacterial species there that allows resistance to transmit. So it's a little bit defined by what you mean by or the pathogen specific, but overall the really key point to remember is that it's antimicrobial usage that drives antimicrobial resistance. That's the absolute key point there. The more you use an antibiotic, the more likely you are to get resistance to that antibiotic. So here, in this instance, I'm just showing two ways. When you get vaccinated, you induce antibody, and you can induce T cells. So if you encounter the pathogen, your antibody acts as a barrier, a wall, if you want to think about this, making it really hard for the pathogen to climb over this and establish the infection. So antibody's job is usually done quite quickly after encounter, in some models show it's within a couple of hours or so. Those very few bacteria that can get past this, or if bacteria get past this, they're there at very low numbers, so they can't establish an infection. And then the second arm of the immune system, called T cells, come in, and then they help essentially vacuum up the remaining mess. And this works slightly differently over time. So your antibody for most vaccines correlates with the level of protection that you see. So why is resistance common against antibiotics but not against vaccines? Well, antibiotics, they usually only have a single target on that pathogen. But bacteria have multiple ways that they can resist that antibiotic. So, for instance, they can have like a water pump. They can pump the antibiotic as soon as the antibiotic goes in. They can pump it back out again. They can also inactivate the antibiotic because they can pick up these enzymes. And here's an example for one which is important for penicillin-like. Then, in other ways, bacteria, believe it or not, have it's called an immune system, but it's just a way of protecting them, usually from other invasive viruses, where they can modify the target, which prevents that antibiotic from actually reaching its and interacting with its target molecule. And then also is that you can have cell surface alterations, which alter how much antibiotic gets in. So you've got usually one target, multiple ways for that bacterium to introduce resistance. And what's more is that many of these resistance mechanisms can be spread really quickly through genetic mechanisms, either through what's called plasmids, which are basically circles of DNA which are easily to spread between bacteria, or from the bacterial chromosome, which is picked up and shared amongst bacterial communities. The key point is that because it's genetic, is that it can be spread very, very quickly. Vaccines, in contrast, they usually have multiple targets that they work through. And even if they work through a single molecule or a single protein, is that there are multiple ways to bind onto that and inactivate that protein. And this redundancy is why they are so successful. Because it means for a pathogen to evade a vaccine, it needs many mutations. And this is, in practicality, this is very, very difficult to achieve, and and even more difficult to enable the spread. So we can see this in this example. Here you got a vaccine which is made up of 3 bacterial components. So you get that vaccine and you make these antibodies against them. These antibodies are Y-shaped molecules, and these bind to the surface of the bacterium. So when you do encounter the bacterium, here you can saturate the surface of the bacterium with these antibodies, and this provides extensive protection. Even if you've got a very closely related bacterium here, so-called, for this instance, we're going to call it a mutant, whereby one of those antigens looks different. So instead of it being black, it's red in this instance. So the black antibodies can no longer bind, the orange and the green can. And this compensates for this variation. And this is why they are one of the major ways that they are so successful. There's another second way, which is, so if we think about this, we could think about this actually working inside an individual. So you get a vaccine, you make an antibody, you're protected against this, and you're protected against the related organism. But we live in a big society with many, many people, and not everyone can get vaccinated, or at least not everyone will, vaccines will work in. I'm happy to take questions on that. But here, this shows then the power of herd immunity. So this is an individual who's infected. And in this case, it's like COVID, March 2020, is that it's surrounded by naive individuals. There is no barrier here to prevent the spread of this infection. So everyone can become infected. There is nothing here to stop this at this stage. In contrast, when we're vaccinated, we now have a number of people surrounding that infectious person. Those who are not vaccinated or can't be vaccinated are also here, but now the pathogen cannot get past this human barrier to infect these other people. And so so the infection dies out with this individual. When it ends here, either through this person's death or they resolve the infection, that's the end point. It's a dead end. And that's really powerful. But what the proportion of a population that you need to vaccinate to achieve this varies by pathogen. So something like measles, it's high, it's well over 90%. And we can see the difficulties of this in Europe now, because we have outbreaks of measles and so on, simply because, not because the vaccine doesn't work, the vaccine's brilliant, just because not enough people are getting vaccinated. So how do vaccines help AMR? So they can do this directly and indirectly, and in the simplest form is through preventing infection and blocking transmission. So labeling this in direct ways is that by reducing that level of mild infections, where the majority of antibiotics are actually dished out for, is that you reduce the need for antibiotic use. You can reduce the development of resistance from forming. So we still use vaccines against tetanus, for instance, and diphtheria that were first designed nearly a century ago. We have no risk of losing the power of these vaccines. And so because the vaccine was introduced before the antibiotic era, is that there's been no selective pressure at all to use antibiotics on these pathogens, and then there's no resistance has developed. We can reduce the burden of infections with existing AMR. And this is partly relating into the question that I answered earlier. So this infection, Haemophilus influenzae, this pathogen, sorry, Haemophilus influenzae B, is a devastating invasive pathogen. And up until about was a major cause of disease in infants, up until when the vaccine was introduced, or more its widespread introduction in the early 1990s. And so at the time, this was obviously antibiotics had been used for 30, 40 years by then. There was extensive AMR in this population of pathogens, Haemophilus Hib, it's often called, and the same for pneumococcus, and the same for Neisseria, for meningitis in this instance. And so by using the vaccine is blind to whether this is antimicrobial resistant or not. Because the vaccine works, this antimicrobial resistant organism cannot establish itself in the host, and so it dies at that time. The host lives, the pathogen dies. Incredible. And Hib has now it's been such a success, is that rates of Haemophilus influenzae B are now well over 95% lower than they were before the vaccine. And then I've mentioned about transmission through herd immunity, and also reducing the opportunity for genetic exchange by bacteria, because you reduce colonization, and then you reduce the opportunity for these to share genetic information with each other as they colonize you. So then there's indirect ways, and you can block transmission, as I mentioned, similarly for herd immunity. It overlaps with this, but also, and this is an area that's becoming more and more of interest, is that you take is the cross protection between different bacteria. So this vaccine, 4C-MenB, it's known in the US, and Bexsero in Europe, protects against meningitis B infections. But what's becoming clear is that although this was introduced to protect against meningitis, it also has a knock-on benefit of providing quite substantial protection, up to 50%, against gonorrhea infections. And what's really beneficial about this is that it shows that vaccination against gonococcus is likely to work, but also gonococcus has, in some instances, it's resistant to nearly all antibiotics. And gonococcus is a major cause of female infertility. So we can see the indirect benefit here. And also related into the mild specific infections is that 50% of antibiotic use is inappropriate. We know that flu season, I'll show you the data in a couple of slides' time, correlates with antibiotic use. And so by vaccinating, we reduce the opportunity or the need to have an antibiotic in the beginning. And of course, this relates in what would be better would be also to have better diagnostics for this. And also, pathogens don't work in isolation. Flu vaccine also reduces the opportunity against secondary bacterial infections. And then if you have this secondary bacterial infection, then of course you're likely to have to need an antibiotic treatment. So by preventing this in the beginning, you reduce the need to have an antibiotic. So I'm going to split this into two. The major focus on this was really to split by age, but the evidence is absolutely without of the greatest level of evidence that vaccination reduces AMR and antibiotic use is in children, and that's because children get more vaccines than adults, and so most vaccines are actually designed to protect the young, and the benefit as time has gone on is that they also protect other age groups. So I've mentioned two, or one of these examples is Haemophilus influenzae B, but there's a really current example ongoing at the moment, which is typhoid. So people may or may not be aware, but typhoid has been an epidemic organism since for well over 2,000 years. It's absolutely devastating in those populations. And in pre-antibiotic era, the risk of death from a typhoid infection was about 1 in 10. Antibiotics have helped control this down to about 1% or so, maybe a bit lower than that now. But there is now a really extensive resistance to antibiotics in typhoid. And this has really encouraged an urgency to deploy next generation vaccines against typhoid. And I'm really happy to say is that these are now pre-qualified by the WHO and being used in children, and hopefully they'll be much more widely available. The key thing about them is that they're exquisitely effective. So depending upon the study, but 95% is roughly in the ballpark where these vaccine efficacy that these are working in. The other thing is that the very recent data shows is that these vaccines against typhoid work independently of the degree of antimicrobial resistance of the infecting strain. So in some parts of Pakistan, for instance, it was so extensive is that you're literally down to either no or your last line of antibiotic. The clear evidence is that greater than 90% by vaccine efficacy against these types of organisms, completely removing the need to use an antibiotic and putting that organism under further selective pressure. Another example here, which I'm just showing to really emphasize it because it looks at this over time. So this is the introduction of a vaccine, a conjugate vaccine against an organism called pneumococcus. And 13 just is its valency, how many different types of pneumococcus it works against. And this is in children under age of 5. And once the vaccine was introduced, you can see that levels of antimicrobial use and so on were going up. These are just different classes of antibiotics. As soon as the vaccine was introduced, is that the rates of invasive pneumococcal disease, and that's what IPD means, and this is the worst presentation of this type of infection, dropped quite dramatically. And so did the level of antimicrobial use associated with this. So anything well over 80% for some of these classes of pathogens. And this makes a really, really big difference. So if we scaled this up, full use of this vaccine, PCV13, is likely to mean 11 million days less antibiotic use each year. Another organism, which is called Group A strep, which is a major cause of pharyngitis and also invasive disease. If we had a vaccine against this organism, Group A strep, it would mean 6 billion less antibiotic doses given yearly. This is enormous reduction on selective pressure on these organisms in humans. So if we look in adults, fewer vaccines are obviously given routinely to adults because if you're between 20 and 60, you're lower risk for most infections. So there's less evidence base on here, and the full impact on microbial use is really still to be understood. These are complex studies to perform. The really good news is that if we look on these vaccines which are used more extensively, then the balance of evidence, particularly for flu, is that they can have a dramatic and massive impact. And so most of the studies here have been in the over 65s, because this is really the break point where it becomes really clear that there's an increased risk. And overall, and there are caveats here, of course, is that the evidence mirrors what is seen for vaccinating children. But also, I mentioned about that PCV13 in the previous slide, which was given to children. There's a knock-on benefit that herd immunity, what was found was that immunizing children also protected, the classic is the grandparents, from invasive pneumococcal disease as well. There was a knock-on benefit. And so this also means is that there's strong evidence that vaccine-mediated protection is independent of the antibiotic sensitivity of the pathogen. And so these effects can be so dramatic is that they can reduce the presence of AMR strains in adults by up to 80%. So overall, the evidence therefore means is that we can vaccination in adults, and most definitely children, without a shadow of a doubt, that the the control of antimicrobial resistant bacteria can be helped by being vaccinated. Again, we have to think about this about the individual, where you are, if you're vaccinated against infection, you've got the greatest likelihood of being protected compared to somebody who's in the same population but not vaccinated. And then the herd effect on this population, because some people can't be vaccinated. So we can vaccinate against both viral and bacterial infections, and both of these help. So if we did a rough comparison side by side, then surprisingly, vaccinating adults against flu may be more beneficial than the pan-vaccination against pneumococcus in preventing antimicrobial resistance. But it's, of course, more complicated than that, because vaccinating against pneumococcus also reduces the risk of some viral lower respiratory tract infections. And basically, the lower the if it goes lower in the airways, the more likely it is to be protective, to be harmful, sorry. So the question is, why is this? And this graph really, the graph I'll show in a second, really shows this. And flu is so widespread. We hear about everything about having a seasonal flu vaccination and so on. This is because flu changes either slightly or dramatically each year, depending upon whether it's so-called antigenic drift or antigenic shift. But also having a viral infection can massively increase your susceptibility to a range of pathogens, including pneumococcus. This key one, this is Staph aureus, Staphylococcus aureus, or Haemophilus influenzae B, and Hib is, we're very lucky, a good vaccine against. So this relationship with pneumococcus, between flu and pneumococcus, is probably the key reason the Spanish flu of 1918 was so devastating. And because you get infected with one, and it predisposes to the second infection, the super infection by the bacteria. So if we look at recent data, and I'm sorry for the scale on this, all this is, each one of these dots is these points is a month. That's all you need to know. And all it's really picking up on here is the seasonality of flu and antibiotic use. So the black line here is the flu season, goes up and goes down, goes up and goes down seasonally. But then, and to a lesser degree with RSV, which is green here, but if you can superimpose your antibiotic use on when you've got your flu season. And so many of these antibiotics will be dished out to because there isn't a good enough differential diagnosis to identify that this is caused by flu. And of course, these antibiotics will not work against flu. So we can see that most of this is likely to be non-beneficial for controlling infection. So I'm summarizing a lot of data here with a couple of caveats within it. Is, of course, if you get your flu vaccine, you decrease your risk of flu, but also you decrease your risk of pneumococcal infection, and this subsequently combined, you get an overall lower use of antibiotics. So I've just summarized this in a sentence for clarity. Vaccinating against flu reduces antibiotic use for viral infection, which is, of course, inappropriate. Vaccinating against flu reduces secondary pneumococcal infections. And so great can this be effect is that you can reduce antimicrobial use in adults by nearly 2/3 and take that selective pressure away. If we now look at the other way, and again, I'm just focusing on pneumococcal disease here, is that, and this is a Dutch trial. So this trial was published about 8 years ago or so, and it was a really, really definitive trial performed in the Netherlands, looking at receiving this vaccine against pneumococcus, or there was no pneumococcal vaccine program before this was at this time. So you can give what's called a placebo. So these guys have got nothing but natural immunity. And then you can look at this. This is CAP is community acquired pneumonia, and then IPD is invasive pneumococcal disease. And the key point is that there's a big gap between the red and the blue in terms of its incidence. So there's a lot of protection, good protection here, about 45% protection against vaccine type pneumococcal infections and pneumonia from pneumococcal infection from vaccine type, but the effect is even greater against invasive pneumococcal disease, and this is the one that you're most likely to die from. And so again, summarizing this is against pneumococcal pneumonia, you see 45% protection against the vaccine strains, and against invasive disease, you get a whopping 75% protection. But also, because these bacteria and viruses which enter the lung can interact, is that you get by knocking out the pneumococcus, you reduce your viruses. And again, this has a knock-on benefit of reducing antibiotic use. So immunization with pneumococcal conjugate vaccine can directly reduce the need for antibiotics. And you can have an effect on the carriage, transmission, and so on, a prevalence of drug-resistant invasive pneumococcal disease by up to 1/3. And this is up to 25% of reduction in some viral infections. And so, but of course, these types of studies are in their infancy, and so more effect may be detectable as the vaccination programs become more established in high-income countries, and then the studies become greater and more widespread. Okay, so last two slides is just to say is that there are many pathogens against which there are no vaccines, and some of this has actually been a reflection of the amazing success of antibiotics. And so this circle here picks up a range of different pathogens which have been isolated from the bloodstream of patients in the UK. In England, actually. And red is just a type of bacterium called a gram-negative bacteria, and the blue is a bacteria called gram-positive bacteria. And you can see nearly half of this number just by two pathogens. Gram-positive called Staph aureus, which you may be familiar with from because of it's so widespread and such a complicated organism to have a vaccine against. And then the second one is E. coli, which I introduced at the beginning. And roughly 1/3 or so of bloodborne bloodstream infections are detected are E. coli's. We need to really understand what effect vaccines can have. And to do this, we need to really be able to identify what causes our problems. And so we're now going into a golden era of better diagnostics and so on. And we're most definitely in a golden era of vaccine development. We have outside of high-income countries, TB is still a huge problem in older people. Group A strep and Group B strep are key bloodborne pathogens. We're in a really good place with Group B strep. The vaccines will hopefully start to be trialed more widely in adults soon. Group A strep again soon. Staph aureus sadly is a difficult one to develop vaccines against. E. coli, a bit of a early stages of the next generation vaccines, and Klebsiella pneumonia I mentioned is quite scary at the moment. I mentioned about the off-target benefits. The more we get vaccinated, potentially the more benefit we get. There's a phenomenon called innate training, which means is that overall some vaccines like BCG may have the benefit of improving your resistance to all infections. And certainly in sub-Saharan Africa, getting your BCG on day 0 of life, on your day of birth, is associated with decreases in all risk mortality. And then we can get cross protection, which I've mentioned before. reducing AMR ultimately means reducing antibiotic use, and vaccines are really a critical way to do this. So this is the last slide, and I just want to put up the summary and points for discussion. Getting vaccinated as an adult, especially as older adults, reduces your risk of infection and the downstream sequelae for you personally, and probably on a more widely on a population scale. But it isn't as great as the effect that we see in children. And this may be because of rates of vaccine uptake and the level of vaccination, different vaccines that are used. Vaccination, I hope, have demonstrated really can aid in antibiotic stewardship. It can help prevent AMR or help prevent an infection by an AMR pathogen. Even just vaccinating against one pathogen, pneumococcus, may help reduce the risk of infections from many different viruses. And of course, the more people get vaccinated, the more this impact. Most definitely, vaccinating against flu is an incredibly, really good idea. So the wider vaccine uptake, as I mentioned, may have broader benefits in reducing AMR and antibiotic use. But there are other factors. It's not advertised enough, it's not pushed enough, really, that getting your seasonal flu vaccination has other real big effect. Is that cardiovascular episodes of cardiovascular associated disease can have a drop of up to 50% if you get your flu vaccine. And that's because you put your heart, when you're ill with a respiratory infection, you put your heart under greater stress. So your flu vaccine can really have a big impact on these other, remember I mentioned about non-communicable diseases before. We're in a golden era of vaccine research and development. Soon, hopefully, there'll be an RSV vaccine which will be rolled out in the coming years. And this has been recently shown to have a big impact in the over 65s at preventing RSV infections. This will have the knock-on effect of protecting against AMR. There are new bacterial vaccines needed, and there are many in the pipeline. But we also need to widen vaccine usage, this herd immunity effect and the cross-infection benefit. But this is as much a political problem as a scientific one. For most pathogens, with the effort, as we showed really quickly with COVID, is that we can have benefits, we can make these vaccines. There is much a political issue here, and I think exercises such as the one that I'm obviously presenting to here, and the workshops like this really help emphasize that. And the lessons from COVID-19. One other factor that we haven't talked about is the potential benefit for repeat vaccination and maintaining those responses either at a higher level or for longer. And then lastly, and this is an offset thing, is that vaccines can save lives, but only when used. The key thing is that vaccination is really, using the vaccine is really what saves lives. And I'll stop there. Thank you.
Thank you, Professor, very much. We have a few questions from the audience. So the first one is, are you aware of any antimicrobial resistance when it comes to invasive meningococcal disease? There
has been, but the vaccines have definitely had an impact on dropping that. So there was, so what... So some of the issue here is that the need to treat is probably what's as important as whether you are antimicrobial resistant or not. Because even in the face of treatment, if you have successful treatment, individuals with infants, particularly with meningitis, will have downstream sequelae problems, that whether that's necrotic tissue and amputation, or whether that's brain damage or other factors, because the organism divides very, very quickly. So you need a lot of activity to line up in a row. You need to be able to recognize that that meningitis is the disease the infant has. You need to be able to then get access to appropriate treatment. You then need to be able to, if you're testing for antimicrobial profiles, for instance, you need to be able to test whether there is resistance in that strain. This all takes time. These organisms can divide extraordinarily rapidly in minutes or hours. in your bloodstream, in your body, in your brain. So where the vaccine works here is by working independently of antimicrobial resistance in that context. So you don't need to use the antibiotic in the beginning because there is no infection.
Thank you. The other question is, could you comment on the danger or risk or favors of AMR? mRNA.
The dangers.
Yeah.
So with all vaccines, any treatment, antibiotics even, there's always a risk in a subset of people of a side effect. RNA vaccines are incredibly safe. We've seen this repeatedly over the last 3 or 4 years. That it's in terms of its usage in humans, it's a relatively new technology. In terms of its scale of usage now, because of the COVID vaccine, then it's incredibly safe. I've had RNA vaccines. I've had the AZ vaccine. I have no qualms at all about it. I think the other benefit the RNA vaccines can have and bring to the table is the sheer flexibility in this as a platform. So you know, it's being used to simplify how you make flu vaccines, for instance, and the ability to respond much more quickly to outbreak pathogens, whether that's viral or bacterial, is in the air. So incredibly safe. The risks of not getting vaccinated overwhelmingly exceed the risks of getting vaccinated on an individual basis.
Very clear. Thank you. So we have one last question. So vaccine resistance is sometimes influenced by the health experts. What do you think is the reason doctors resist vaccines? And then during COVID-19, doctors prescribed antibiotics to patients from the moment they were test positive, and antibiotics continue to be prescribed in similar cases. Do you think it has contributed to AMR?
There was a study published recently looking at this, and some of this is hindsight. So, as I mentioned, when you get flu, quite often you get a secondary bacterial infection, and there the relationship is really, really clear. When we had COVID, it wasn't clear. So good practice at that time was for more serious COVID infections, hospitalization, etc., was to administer antibiotics to try and deal with it. What was found was that retrospectively, or as the pandemic evolved, is that co-infections with other pathogens were quite low in proportionally. So it was a few percent, and then secondary bacterial infections were also relatively low compared to what's seen with other pathogens. So the studies that have been published tend to show is that when you look at what happened there, that there could well have been an influence on AMR by administering the amount of antimicrobials at that time. But probably what was the key point is that many of the pathogens which were in circulation were already antimicrobial resistant. So there's a caveat on this as well, which is in the rate of the AMR positivity was higher in low to middle income countries, for i.e. the circulating pathogens in low middle income countries were much higher. You were more likely to have AMR there than in high income countries, which reflects what's quite broadly seen anyway. because you have a higher infectious disease burden in low middle income countries than you do in high income countries. So there were lots of antibiotics administered, particularly for serious infections. The full likelihood of it is unclear. Driving AMR, it probably wouldn't have helped reduce AMR. It's probably fair to say. The second part of your, it was your first part, sorry, about resistance to vaccines. It depends what you mean by that. There is no meaningful resistance against most vaccines which are used, particularly in childhood. There can be something in pneumococcus is called serotype replacement, and this reflects the sheer diversity of pneumococcal bacteria. So you can think of these as there's roughly 100 different types. So you can call them 1 to 100 if you want to call it for simplicity. So that PCV13 covers 13 of the most widespread of these, but that means 87 or so aren't covered. So the evidence is absolutely clear that your risk of infection with those 13 drops absolutely enormously if you get PCV13. But against the 80 is some of those, then what you can have is something called serotype replacement, where because you've now made space, you've cleared the space where those 13 were occupying, others can come in. That is also being dealt with up to a point by the introduction of vaccines which cover more of these, up to 20 plus different types of these types of pneumococcus. But vaccine resistance in the way that you get antimicrobial resistance just isn't an issue.
Very clear. Thank you. We're running out of time, so I will just read one last question if you allow me to.
Yeah.
So regarding RNA vaccines for bacterial pathogens, can prokaryotic motifs of bacterial antigens be expressed in eukaryotic organisms such as humans? Can RNA platform work for bacterial infections?
So it's a great question. So one of the background to this is that the surface of bacteria look different in the main to the surface of viruses. So the fundamental answer to that is that there is a good, I know that there are a range of bacterial vaccines based on the mRNA platform which are being trialed, and these are in so-called phase 1 or in some possibly in phase 2 now, I forget. So it fundamentally comes down to how the protein folds. There is good evidence that they can fold appropriately depending upon the nature of the target protein. But you are right fundamentally that greater care needs to be applied to understand how the mRNA technology can be used in that context. What's exciting about the mRNA technology is that you can play with it in a way that you can't do with other technologies to the same degree. So you can give what are called multiple subunit vaccines in one go. So that'd be very similar to those triangles I showed in an earlier slide. Instead of having 3 triangles, you could have 6 triangles. And we know that this has been employed successfully against some infections, like the acellular pertussis vaccine is made up of 5 or so subunits. So the RNA vaccine, it's nearly as easy to make one antigen, as they're called, compared to 5 antigens. So the flexibility in this is great without having a big effect on necessarily on ultimate cost. But the mRNA platform, it will be one tool to address this alongside many other tools.
Thank you. Thank you very much, Professor, for the interesting lecture. We have come to the end of this training session, and as always, the list of thanks is quite long. First of all, thanks again to Professor Cunningham, and thanks to all the people who connected from more than 10 countries. I would like to recall that this European training session was made possible by the unconditional support of the 5 companies supporting the 3rd edition of our VaccinAction project. So thank you to GSK, J&J, MSD, Pfizer, and Sanofi. Thank you also to our 2 media partners, Vaccines Today and Transanità Policy and Procurement in Healthcare, and to all the colleagues who worked on this initiative, especially Daniela, who is the VaccinAction project manager. As usual, the presentation shown today by Professor Cunningham will soon be published on our website. And regarding the next steps of our work on vaccination policies, I hope to see you at the resumption of work in 2024. In fact, we are organizing a policy dialogue event in the European Parliament with the aim of emphasizing the importance of ensuring that vaccination policy remains central after the European elections in June 2024 and throughout the next parliamentary term. We will, of course, keep you informed through our newsletter, website, and social media channels. I take this opportunity to wish you happy holidays and a good continuation of the day. Thank you.
Bye.
Bye.
Thank you, Professor.
Okay, see you.
Bye.
Just making sure I'm done. Cheers. Was that okay for the European context for you as well?
It was fine, extremely useful, and also the feedback were extremely positive. So thank you very much. We will publish your presentation in a couple of days.
Yeah, no worries. Yeah, if you could send a link, that'd be quite useful. I'm
For
sure
sure.
I made a couple of mistakes.
Will do. Will do.
All right. Thank you. Bye.
Again, all the best. Bye-bye.